Now let's shift gears and look at some of the major cancer drugs. For all of these drugs, the goal is to slow down or completely eliminate further cell growth and proliferation. The important part is remembering how each of these drugs accomplishes this goal. Do you remember the stages of cellular division in the cell cycle from biochemistry? Well, this is one good way to organize how we think of the action in these cancer drugs. Different drugs have been developed to affect each stage, and this concept is directly tested on the USMLE exams. Antimetabolites affect the S phase, where DNA synthesis occurs. Etoposides affect the S phase, but unlike antimetabolites, etoposides also affect the G2 phase. Bleomycin is another great agent that blocks the G2 phase, and several drugs affect mitosis, including the vinca alkaloids and taxols. Vinca alkaloids also affect the S phase. After we go through the mechanisms of action for each of these drugs, you should come back to review this image to help you put it all together. A different way to organize these cancer drugs is by their target, specifically nucleotide synthesis, DNA, or cellular division. This is another good organization scheme to consider once we go through the mechanisms of actions in detail. Antimetabolites work by inhibiting the synthesis of nucleotides. Without nucleotides to support DNA replication, cancer cells are less able to divide. So why would this not affect non-cancer cells of the body? Well, to tell you the truth, it does. The major difference is that cancer cells are dividing at an incredible rate, and so you're going to interfere with their cellular division at a much higher rate. At least a much higher rate than non-cancer cells of the body that are just kind of hanging out in the G0 phase and not rapidly dividing. So it does affect every cell in the body. The important point is to what extent it affects each cell. There are several antimetabolites, including methotrexate, 5-fluorouracil, cytarabine, and azathioprine. Many of these antimetabolites work on thymidine synthesis, more specifically, the ultimate conversion of DUMP to DTMP that you might recall from biochem. This process requires methylene tetrahydrofolate and yields dihydrofolate, which must be then converted back to methylene tetrahydrofolate in 2 steps. The first step in this conversion requires dihydrofolate reductase, and methotrexate acts as a folic acid analog that inhibits dihydrofolate reductase, and thus the eventual conversion of DUMP to DTMP. So basically, methotrexate acts by decreasing the available DTMP, eventually inhibiting the DNA and protein synthesis. Methotrexate works well for leukemias, lymphomas, choriocarcinomas, and sarcomas. Can you think of other common uses from other subjects? Methotrexate is also highly effective in ectopic pregnancies and in low doses for irritable bowel disease, rheumatoid arthritis, and psoriasis. Toxicity for methotrexate basically stems from the fact that it blocks folic acid synthesis, and even though that's killing the cancer cells, your normal cells need folate too, so they suffer. Toxicity includes myelosuppression, pancytopenia, macrocytic anemia, macrovascular fatty changes in the liver, and hepatotoxicity, mucositis, and teratogenicity. You can also see abscess ulcers, which are canker sores of the mouth, and interstitial pulmonary fibrosis. Since all the side effects of methotrexate occur because it blocks folic acid stromal functions, they can be more or less reversed with high doses of leucovorin, a folic acid derivative. 5-fluorouracil is a pyrimidine analog that inhibits thymidylate synthase directly. 5-fluorouracil is effective in solid cancers and can also be used topically in basal cell carcinomas. Toxicities include myelosuppression and photosensitivity. Unlike methotrexate, 5-fluorouracil is not reversible with leucovorin because its effects are downstream of tetrahydrofolate. In the event of an overdose, you can give thymidine directly to bypass the drug's effect. Cytarabine, otherwise known as RSC, is a pyrimidine analog that inhibits DNA polymerase. It is used in both leukemias and lymphomas. 6-mercaptopurine and 6-thioguanine are both purine analogs that inhibit de novo purine synthesis. They are used in hematologic cancers, preventing organ rejections, rheumatoid arthritis, lupus, and irritable bowel disease. Azathioprine is a purine analog and is a prodrug of 6-mercaptopurine. Analog means that it's very close to the real thing, and if you look at azathioprine, you can tell it's close to a purine, because all you have to do is add a U right here at the end, and you get purine. Both azathioprine and 6-MP inhibit de novo synthesis of purines. Here's a quick throwback to biochemistry. What enzyme would activate these two drugs? Well, do you recall the enzyme that activate purines? That's hypoxanthine guanine phosphoribosyltransferase. Let's just say HGPRT for short. And this enzyme is defective in what disease? That's Leach-Nyhan syndrome. Another important fact about azathioprine and 6-mercaptopurine is that they are metabolized by xanthine oxidase. Can you think of a reason that a person undergoing treatment for gout would have to worry about taking these two drugs? Well, if you're a patient that was taking allopurinol, which is a xanthine oxidase inhibitor, then you would be giving a chemotherapy agent in azathioprine or 6-mercaptopurine that the body could not break down. Allopurinol will inhibit the degradation of these medications and therefore greatly increase the toxicity of these medications. Toxicities of these drugs include bone marrow depression, GI, and liver damage. 6-thioguanine, on the other hand, belongs to the same family as azathioprine and 6-mercaptopurine, but it is not metabolized by xanthine oxidase. This means it is okay to give with allopurinol. Side effects include leukopenia, thrombocytopenia, and megaloblastic anemia. It also has a cerebellar toxicity. The anti-tumor antibiotics act directly on DNA. Actinomycin, or Actinomycin D, intercalates DNA, and works well for Wilms tumor, rhabdomyosarcoma, and Ewing sarcoma. If you think about the epidemiology of these diseases, they're all childhood tumors. A good way to remember that Actinomycin D is a good drug for childhood tumors is the mnemonic, "Children act out." Like most anti-tumor agents, toxicity includes myelosuppression. Doxorubicin and the related Daunorubicin generate free radicals that cause breaks in DNA. They also intercalate DNA, decreasing replication. Doxorubicin is used in solid tumors, leukemias, and lymphomas. This is probably the anti-neoplastic with the widest range of clinical uses discussed so far. Do you recall an important toxicity that is commonly tested for doxorubicin? One of the most important points on the exam for this drug is that doxorubicin can cause congestive heart failure due to dilated cardiomyopathy, as we see in this photo. It is such a worrisome side effect that they've developed a medication called dexrazoxone, an iron chelator that helps decrease cardiotoxicity. Like other anti-neoplastics, doxorubicin can cause myelosuppression and alopecia. Bleomycin creates free radicals, which induce DNA breaks and work during the G2 phase. Bleomycin is used in testicular cancers and Hodgkin's lymphoma. The main toxicity to remember is that bleomycin is one of the few drugs that can cause pulmonary fibrosis, which is very severe and life-threatening. It can also cause skin changes and mucositis. Alkylating agents are anti-cancer treatments that attach alkyl groups to DNA. Since cancer cells are rapidly dividing, they are more susceptible to alkylation damage than normal cells. Cyclophosphamide and ifosfamide require bioactivation by the liver and are effective in non-Hodgkin lymphoma, breast, and ovarian carcinomas. Do you recall any toxicities for cyclophosphamide? A distinct side effect is hemorrhagic cystitis, which results in patients presenting with hematuria. Hemorrhagic cystitis can be prevented with mesna, which acts by binding toxic metabolite produced by these drugs, and is also commonly tested on the exam. Nitrosoureas are unique in that they can cross the blood-brain barrier, making them effective for brain tumors. This means that they can also cause CNS toxicity, including convulsions, dizziness, and ataxia. Busulfan is used prior to bone marrow transplantation. It essentially destroys the recipient's bone marrow, and hopefully all the cancer cells along with it. It can also be used to treat CML, but do you remember the mainstay of CML treatment? That would be imatinib, the antibody that directly targets the runaway tyrosine kinase in CML. Like bleomycin, busulfan can cause pulmonary fibrosis, and in addition, busulfan can cause hyperpigmentation. There are two groups of microtubule inhibitors, the VIN group and the Taxols. The VIN group includes vincristine and vinblastine and acts by blocking microtubule polymerization so that mitotic spindle formations cannot form. These target both the M and the S phase of the cell cycle. They are used in solid tumors, leukemias, and lymphomas. Vincristine causes neurotoxicity, including areflexia and peripheral neuritis. But why? That's because neurons rely on tubules for axonal transport across their very, very great length. So if you stop tubules from polymerizing, the nerves stop working. It can also cause paralytic ileus. Vinblastine can also cause bone marrow suppression. Remember, vinblastine blasts the bone marrow. The taxols, like paclitaxel, work by hyperstabilizing the polymerized microtubules so that the mitotic spindle cannot break down. This means that cells cannot progress from the metaphase to the anaphase. Taxols are useful in ovarian and breast carcinomas. Toxicities include myelosuppression, alopecia, and hypersensitivity. As a review, how do you treat the pathognomonic side effect of cyclophosphamide? Well, first we need to recall what that side effect is, and it's hemorrhagic cystitis. The medication given prophylactically with the administration of cyclophosphamide is Mesna. The platinum agents, cisplatin and carboplatin, cross-link DNA. They are used in carcinomas of the testes, bladder, ovaries, and lungs. Any known toxicities for these two agents? Toxicities include nephrotoxicity and acoustic nerve damage. You can prevent nephrotoxicity with amifostine, a free radical scavenger, and chloride diuresis. Platins are some of the most infamous emetics, which basically means that they cause terrible nausea. There are a number of agents you can administer to try and control the nausea, such as metoclopramide, which is a D2 agonist. Etoposide and Teniposide are two drugs that inhibit topoisomerase II. Remember this guy from biochem? If so, you may recall that inhibition of topoisomerase II increases DNA degradation by halting the unwinding and religation of DNA that topoisomerase II is responsible for. To remember this mechanism of action, it may be helpful to note that Etoposide sounds a lot like topoisomerase. Again, DNA degradation is a good thing in cancer treatment because it specifically targets rapidly dividing cells like cancer cells. What other rapidly dividing cells in the body are also affected? Well, the lining of the GI tract, the immune system, and hair follicles are all naturally rapidly dividing cells. This is why we see so much GI irritation, myelosuppression, and alopecia as side effects of these specific drugs. Both of these drugs are useful in solid tumors, particularly testicular and small cell lung cancers, as well as leukemias and lymphomas. Irinotecan and Topotecan specifically inhibit topoisomerase I instead of II. Irinotecan is used in colon cancer and Topotecan in ovarian and small cell lung cancer.